Good evening, everyone. And at the outset, I wish to thank Professor Jacob Upadhyay, Professor Walter Shewhart, and Professor Ram Sevak for their kind words. And I will try to be professing the true things, And this is actually, the structure of my lecture is going to be, I'm going to give you a little background about myself, because as you heard from Prof Ram Sevak, I have to admit that although we all call him Professor Ram Sevak, being a linguist, I have to call him Professor Ram Sevak because that is the exact meaning of a servant of God. Ram Sevak means servant of God. Actually, if I say Ram Sevak, the meaning gets distorted. So I have to call him Professor Ram Sevak, right? So. I think you would have known about it. Ram Sevak means servant of God. So I'm going to give you a little background of myself, and then I'm going to touch upon how quality of healthcare is being currently measured, and I'm going to say about how the mortality rates are being the major measurement of quality currently. And what are the pitfalls of the existing measurement models, and what we did as innovative models, and then how my research focused on the cost of ICU care and how it is relevant, and are we using our ICUs appropriately, or we are going to see from our research. And I'm going to utilize this opportunity to actually try to boost the image of anesthesiologists, because as you all know, even within the medical fraternity, to be honest, anesthesiologists are not, anesthesia. When I went to US first time, so I said I was in internal medicine for 6 years and I took anesthesiology. You became an anesthetist? Yeah, so they were, and I always say that, the only surgeon who listens to me is my wife anyway. So. So it's always a love-hate relationship between me and between anesthesiologists, and I'm going to use this this forum to boost the image of anesthesiology as a short. Right. This is where I came from actually, and as you see, it's in the tip of the peninsula, very close to Kerala, and that is my small village where I was born, and this is my house, and this is how they still have the functions in the front of the house, or the whole community joined together. And I was impressed when I went to Pinal with bluebirds and everything. The tradition is still maintained in Trinidad, and there's a lot of communitarian feeling. I was so impressed by that. And these are my parents, and although he looks like a pundit, he is a mechanical engineer actually, and because he was actually personally, he didn't, he couldn't apply his mechanical engineering in his personal life. He got into the administrative file reading stuff, and when I joined my engineering, one of those premier institution, he told me, no way, you're going to medicine. So I had to quit engineering and I came to medicine. So this is the college, the medical college which I studied, Tirunelveli Medical College, which is further down south, close to the tip of the peninsula. And as you can see, they don't have a problem with parking because it's every two-wheelers. Even I had a cycle and two-wheeler and all that. And this was the hostel where I was completely ragged, and this fountain has dirty water which we have to take a bath before going to the hostel, all the juniors. And if you notice, it says House of Lords, but I know what happens inside is not the Lord's business anyway. And as you know, India is a cricket mad country, and we will be surprised that in this college we had a Viv Richards fan club, and if India is not playing, all right, West Indies is the team we all support, and actually now I'm satisfying all those West Indian thing. When I came in here, when I saw cricketers, I just go, can I have a photograph with you? And so I have a photograph with Chris Gayle and Dwayne Bravo and everybody. Dwayne Bravo came to my consultation room. For some consultation. I said, No, you don't tell me anything. First, let me get my cell phone and first photograph. So this was the small rented house where we stayed in my in the state of Pondicherry, where my dad was employed, and as you can see, the old tiles, they're absolutely cool atmosphere, but a lot of scorpions and rats and everything. So, and these are, I mean, I was practicing in internal medicine for almost 6 years before I joined my anesthesiology. Recently, when I went home, all my patients were like, they were asking me, when are we coming back? I mean, my brother-in-law was there and he just clicked everything, when I was stopped by my patients, and so he sent all the photographs. So I thought I'll show you all my patients, they're still expecting that, I'll be coming next year because, I mean, he has a house here, so he's going to come. And then I went to Manipal. You all know about Manipal because we had a training program with Manipal. And, from a very humble district general hospital, I just went to a high-tech Manipal with all touch screens, and I was flabbergasted with all those monitors. And again, to come back to district general hospital with hand-on pulse and no monitors. I got trained in a residency program in anesthesia with all high-tech monitors. And then I went back to my district general hospital, and they said, what ECG monitor? No, it's not for, it is not for theater. So that is the spectrum of things in India. And then I came, as Prof Ram Sevak told you, I came to Queen Elizabeth Hospital, and Dr. Kumar, he's the gentleman, A.Y. Kumar, he's a senior lecturer there now. He's person who brought me to Caribbean. He just called me one fine morning, do you want to come? I said, okay, I'll try. And then this is Professor Mosley, and then Dr. Chen, actually, then I came here and met him for research and everything, and then I came to know that there is a post vacant, and Prof Narayan Singh was so inspirational to me. I mean, he came to Barbados as an examiner, and he said, no, you have to apply, you must apply. And so I thought, okay, I will come to Trinidad. I wasn't very sure. I mean, I heard about Trinidad, but once I came in here, I got just blended into the culture, and I could not even think of going anywhere else. And and I got this, and I liked this post because, I mean, I always believe that teaching is always learning. So, I mean, I had the opportunity to teach, so I can learn more. And then, I mean, after I came here, me and Dr. Chen thought that we have to have a logo for our unit. And you can see that, I was so fascinated with steel pan from then. I told the guy that you have to have a steel pan in the background. So our logo has a steel pan. So that was one of the reasons, I mean, I was attracted to Trinidad. Now let's go to the meat of the subject. Now I'm going to give you, I'm going to provoke your thoughts by giving two case scenarios which are actually real cases. Now, it was a 25-year-old gentleman who had a suspected swine flu. I'm trying to actually, because it was meant to be a public open lecture, I'm trying to avoid medical jargon. My colleagues and my technical people hopefully will excuse me. And he was very severely ill, and his oxygen in the blood was very, very, very low. He was on full ICU support, mechanical ventilation, all the medications including Tamiflu, Acyltamivir, everything was given. He stayed in the ICU for 3 weeks, and he was discharged out of the ICU alive. He had a 27-year-old lady, he suspected swine flu again, same scenario, severely ill, no oxygen level was very low. She had exactly same type of treatment, mechanical ventilation, all medications were given. She stayed for 5 weeks, she unfortunately demised. Now I'm going to ask you one question, that did anything go wrong with the ICU care for the lady? I know that we did exactly the same type of treatment. Was anything extra done for this gentleman? I am not aware of anything because I was involved in both the patient's management. So is it right to say that the quality of ICU care was poor just because this lady died? So because it's a sensationalism in the media currently, and that is why I'm using this actually. I'm not saying that the media is bad, or I don't use words like vultures and all that, right? So I'm just trying to say that I mean the sensationalism of media is that I mean they touch on a very, very sensitive issue of death, and see that aftermath of baby's death, public more aware of poor quality health care. Poor quality health care, I mean, so this, if you read this alone, it's going to translate to you that, okay, a baby died, so it has to be poor quality health care. Absolutely no information of what the baby was suffering from, how sick the baby was, and how much the healthcare practitioners and providers try to save the baby. I mean, that is the type of sensationalism we are facing now, and I wanted to actually use this opportunity to explain further on that. Now, what is quality in general? In general, what do you mean by quality? It's a very confusing concept. There's no universal definition, and somebody told in 1931 that it's a goodness of a product. And actually, they conducted a survey where 86 firms in USA, the managers were asked, how do you define quality? See that answers. Somebody said perfection, consistency, eliminating waste, delighting, pleasing customer. Everybody had their own ideas. So we cannot have a real concept of quality. It can be based on a product. Like I put this photograph because I was in crop over playing Mars in Barbados, and it was not even a digital camera those days. I had to go with the film roll, and then I had to scan it, and I don't even know how many pixels or megapixels it has. So you can actually say quality of a photograph is pixels per inch or megapixels, and I mean that is one way to define quality. And fitness for intended use is another way to define quality. Actually, I don't know, you would have known about the the evolution of Datsun. Datsun was introduced to the United States from Japan, and there was a big problem with Datsun. Everybody said, oh, that's a waste of time, that's not a good car. And they conducted so much of quality survey, and they incorporated all those the customers' requirement, and because they could not bring back Datsun as Datsun, because Datsun already has gone into that disrepute, they had to change it to Nissan. So I mean some quality actually can be decided by the user-based criteria. So there cannot be a single definition what is quality. There is a difference between manufacturing and the service sector, and as you know, healthcare is a service sector, and is very, very difficult to define the quality in healthcare, and it has to be tailored to the specific needs of a specific organization. Now, there are many definitions, and I found this one. I mean, American Medical Association has this quality definition, this definition of quality. It says consistently contributes to the improvement or maintenance of quality and or duration of life. I have a little issue with the and or, because maintenance of quality of life is fine. I mean, duration alone, I don't think it can be quality. I will explain further during the course of my lecture what I mean by that. And healthcare quality assessment is not very, very easy. It's too complex. Even now the question lingers if we can assess the quality of healthcare at all, and we cannot until now claim the capability of assessing healthcare quality to the maximal level or the optimal level even. Now, Avis Donabedian was one of the pioneers in healthcare quality. He suggested that healthcare quality should be approached in 3 particular ways. What is the structure of the healthcare, process, and outcome? I'll tell you what it is. Structure is what we mean as the attributes of the setting in which the healthcare is being provided. What are the available human resources? What are the material resources available? What are facilities available? That is the infrastructure of the healthcare. Now, the process of healthcare is what is actually done to the patient, and how a diagnosis is being made, how a treatment is being implemented. That is the process of healthcare. And then comes the outcomes, which is the end point or the end result of the patient's encounter with the healthcare system, what happens to the patient at the end of the process of healthcare. So, how are they being measured differently? There are plenty ways to measure them, but as you see, for an organization, it is always the mortality rate, which is being now taken as the performance metric for a quality healthcare. Now, I don't know if you all know about US News and World Report. This is from 1990 they publish. What they do is they conduct surveys to rate the hospital's attributes. They just do a survey and say what all you have, what type of human resources, material resources. Okay, they get a data. For the process of healthcare, you know what they do? They call the physicians, like 5 or 10 of board certified physicians, and say, name 5 hospitals in your area. So they give, okay, Eric Williams, Port of Spain, San Fernando, according to their own this one. And that is what they take into consideration. And they have acknowledged that that's a problem, but they don't have any other way to measure the process of hospitals. And then they take the Medicare data, claims data, and then take the outcomes for, and then now they come out with some sort of a hospital quality index, which is now going to tell that, oh, these are the best hospitals in US. So, you know, they have the PRO exercise now. You can see that in American Way magazine, when you go by American Airlines, America's top doctors and top hospitals, and all this PRO exercise will come, and based on this type of an assessment, and that is how they do it. And specifically when for a ICU performance measurement, we all know that, you know, I mean, since the time of introduction of critical care medicine, intensive care medicine and critical care medicine is a budding specialty, if you all know. It's few decades old, and you know, I mean, the main aim of critical care is to prevent death. That has been acknowledged by so many authors. And the ICU performance is currently measured in terms of patient death. How do we do it actually? We actually, I don't want to go into the details of these models and everything, but because it will be too complicated. But what I wanted to tell you is that, you know, there are some scoring systems where when the patient comes in, we see how severely ill these patients are. And depending on the age and the severity of illness and all that, we give them a score. Like age, acute physiological status of the patient, and the chronic diseases the patient has, everything is taken into consideration. We give a specific score for each factor of this patient, and the score will tell us if this patient will survive or not. Like for example, APACHE. APACHE is the most, APACHE is not the APACHE Indian thing. You know, APACHE is acute physiology and chronic health evaluation. That is the APACHE, I mean the acronym. You will see many acronyms like this, you know, don't get, you know, boggled and, you know, flabbergasted. Now, this score, we will say, oh, this patient has an APACHE of about 25, so he is very, very sick. So the probability of mortality is this much. That's what we see now, right? And then we compare it. Now, I was intrigued by this particular system because, you know, I mean, I come from Tamil Nadu, and we have this author. He was supposed to have lived, I mean, between 2nd century BC or within like 5th century AD. And he actually was a revolutionary poet, because on those days actually the Tamil poetry should have minimum 4 lines, otherwise it's grammatically it will be dismissed. And when he presented his couplets, it was dismissed by the literature, the giants, but it still stands to you know, I mean, all the tests and everything. And the Tamil people are very, very proud of this gentleman, and that is why they have erected a very tall statue in the Cape. So this, those days, he had written that, you know, I mean, I'll have to tell you that, you know, Uttran alavum, pini alavum, kalamum, katran kardi cheldi. It's a small couplet. That means it says you have to see the age of the patient and the severity, illness of the patient, and the duration of the illness are the 3 factors which any doctor has to take into consideration. So they have already identified 3 factors in those days, and then we have now 12, APACHE has 12 factors, right? So with these 12 factors, what we do is we predict the overall mortality for an ICU. For example, if I apply this scoring system to a Mount Hope ICU, and this scoring system is telling me that, okay, 20% of your admissions should have died. okay, according to the risk adjustment. Now, we see how many patients died here, or how much percentage of the people died. So, that is the observed death rate. So, if 20% should have died and 18% only died, that means you are doing good. Okay, but if 20% should have died and your mortality rate is 40%, that means something is wrong. That is the current way of measuring performance of ICU and even benchmarking ICU performance. This is how we currently do it. I did that in many places. I mean, we started by doing in this same type of APACHE evaluation in a surgical intensive care unit in Barbados. Then we did it in Trinidad. And then, you know, for every healthcare unit, you have these risk adjustment models, and that's why I said you will be facing more and more acronyms. And this is called a Trauma Injury Severity Score, TRIS, like an APACHE. So we did that here for the trauma care in emergency department. And then, actually, there are other models, like this is called a CR POSUM, which is a colorectal POSUM. So we applied this in all the hospitals, public hospitals in Trinidad, to see what is the risk adjustment model and how is the performance of surgery with respect to colorectal cancer surgery. All right, and then we did, you know, a pediatric index of mortality for children admitted in the pediatric ICU, and we did that in Barbados. We did that in Trinidad, and then we applied this what we call as a ERO score, which is something, a model for evaluation of coronary artery bypass grafting surgery, which was done here in Trinidad as well as in Barbados. Now, we did other things like therapeutic intervention scoring system, simplified acute physiology score, and, you know, I mean, these are some of the things which, so many things we did. The end result, and after doing all this, I thought I would write a review article on all this risk scoring, and actually we wrote a review article also. Now, there is a real controversy if these models and the death rate alone can measure a performance of an ICU in the real sense. And I have to say you that most of the models we applied, all the ICUs graded, you know, I mean they were graded in honors. Everybody had less mortality than the expected mortality. That means everybody is doing good. So we couldn't go further on any of those quality improvement because everybody is doing good. When I applied prognostic models in Trinidad, in Barbados, the observed mortality is always less than the expected mortality. So there is something problematic there. So we don't know whether it is a grade inflation, whether it is giving the correct grade for the performance, or they are really performing well. So these tools cannot measure that type of it cannot distinguish between the two. This is because, you know, all authors of these scoring systems have acknowledged that these systems were all developed in some other geographical regions, in some other hospitals, where there is a completely different type of case mix and completely different type of care, and it cannot be adjusted to different. I mean, they say that yes, you can apply it but tailor it, and, you know, you have your own patients, you know, but, you know, for a Trinidad, you know, if we have to do for 20,000 patients, we need to develop our own model, and we have to wait like next 20 years. So we can't do our own things. So what happens is, in these scoring systems, you know, the structure and the process of these units can be good, but outcomes can be poor because there are so many factors which are not under the control of physician. This is why I told you I gave you those two case scenarios where exactly similar type of treatment was given to both of them, 25-year-olds, 27-year-old. One survived, one died. We don't know. There are so many factors which are not under the control of physicians. So that is why we were actually questioning whether these systems are really useful, and I wrote an article about what is the science and art and the creeping commercialism. Because, you know, if you see if you go onto the internet, you know, they will say, I mean, I don't know if you all know about ambulance chases in US. You know, when patients when people get into accident, the lawyers go behind the ambulance and say that, I can get you so much compensation. So, they are called ambulance chasers. And they use all these TRIS methodology and everything and in the court and say that, see, this man has so much injury severity score, so I need, $250,000 as the compensation and all that. There are a lot of creeping commercialism in using these type of models. And that is why, we are in need of models which incorporate all the three factors, structure, process, and outcomes. And it has to be applicable in most regions where we practice. And as I told you, these models which I told you just now, they do not tell you how to improve the quality. They say there may be something wrong, but how do you improve the quality? We don't know. And that is why we developed some innovative models. We performed a marriage between medicine and management, and we took a lot of management tools and we applied into healthcare for performance measurement, which was quite innovative. People haven't done it quite often. This particular application of something called an analytic hierarchy process. And even within the management arena, it was never used for performance measurement. It was like, multiple attribute decision making model where, if you have Toyota, Nissan and, Ford, which one to select? And that exactly is the way, they described this AHP, analytic hierarchy process. It's a lot of matrix mathematics involved. And actually, to be honest, it took 3 years for me to publish this paper, because medical people did not understand the management aspect and management people did not understand the medical aspect. So actually, I struggled, I would have sent it to like 20 odd journals, and then fortunately in Journal of Critical Care is one of those top flagship journals in critical care. We could publish it, and it attracted editorial commentary that it was it is a completely new approach. And then we actually applied this model to a whole hospital, which I was telling you about, the America's best hospitals, about the performance measurement and the process base, and we actually did that for the process based performance of tertiary care hospitals. And then we took other tools such as logical framework, and then something like a QFD, quality function deployment, and then cause and effect diagram, and so many SWOT analysis. We did so many of those management tools. And then, these were all recognized by the medical and the management people as innovative models, and we suggested them as alternative models. Instead of just relying on only death and mortality rates, we have to see what is the structure, what is the process of healthcare, and what are the outcomes. We incorporated everything. It's not that outcomes are not important. It is important, but it has to be incorporated into a holistic approach. Now, the major thing which we did is about the cost of intensive care, and you all know that intensive care is a very, very expensive care unit. So we did this particular evaluation. Our students were so, I was so impressed by the students, undergrad students. They were very, very, without even knowing much about in the details of the intensive care. They collected data and they helped us. And we did the cost evaluation of the intensive care applying the cost block models. Now, these are the results of those models, where you can see that the majority of the chunk of the pie for the cost goes for staff salaries in the ICUs, which is not uncommon. This model has been applied throughout the world, and they all found the same thing, that the staff salary is the major chunk of the expenditure. If you see now the annual cost per ICU, this was actually 2006 data, and I have to warn you that with the current inflation, it has gone up further so much currently. And as Prof Ramsevak said, I'm doing the current thesis on cost effectiveness, so I know that it has gone up further. But when we did this research in 2006, the annual cost of a public ICU was around $9 million, which is still half of the price what they did in what they spent in UK. They spent like 18 million TT dollars per ICU, and per admission it was closely around 30,000, but it varied actually. The cost per patient was around 4,400, but it varied from 4,000 to like around 12,000, depending on the the need for organ support. Now, these were the exact denomination. A private hospital actually gave us the exact figure, approximate figure, but they didn't want to give the details of it. So you all know that the ICU care is offered free of cost in all our public hospitals, okay? But the question is, are we using our ICUs for patients who will be really benefited by the ICU care? You know, I just relinquished my post as head of the anesthetics and ICU. For the past 2 years, we used to have review of mortality, all the patients who died in ICU, and every week, every Friday, and we'll be surprised to see that, you know, why we admitted these type of patients. Because from the beginning, we will know that, you know, I'll give you some case scenarios. These are real case scenarios. I'm not fabricating anything. This was a 66-year-old male who was diagnosed with a pancreatic problem. He had multi-organ system failure. He was in a very moribund state. He was receiving 20 times the maximum dose of the medications to increase his blood pressure. It was less than 60. And he had 3 cardiac arrests in the emergency department and 2 in the ICU. And he continued to receive a full range of ICU interventions until the inevitable happened. We had another case, 86-year-old male, twice operated within a week for subarachnoid. He had bleeding inside the brain. He wasn't responding to any stimulus in the post-operative period because of the extensive stroke, and he was there for 3 weeks and just, you know, and then he died. We had a 65-year-old lady who had severe lung disease, known to have a severe COPD, previously known lung disease. She was diagnosed